I want to talk now about the rather unusual notion that one might prescribe heroin to people with a heroin addiction problem. We've recently completed quite a major randomized trial studying this approach, and it needs some explanation to be able to see why it's both so interesting and so important. First of all, we need to realize that we have good treatments in the heroin addiction field. We have both medication-based treatments like methadone or buprenorphine treatment, and we have other wider rehabilitative treatments like residential rehabilitation or people entering Narcotics Anonymous and 12-step treatment programs. But we have a stubborn group of people where whatever we've tried to do with our treatment, it hasn't seemed to work. We have people who have come back time and again. They've been through residential treatment, they've been through methadone treatment, they've usually been through prison several times, and we appear not to have been able to make any difference. So in a way, the scientific as well as the clinical and policy question is, are these people untreatable, or is it that we just haven't been able to gather together the sufficiently powerful intervention to work? And we've had heroin prescribing in the UK for more than 100 years. It's a drug that we have as a medicine in our medicine cabinet, and it's been used in the addiction treatment field and largely was deemed not to be valuable, not to be successful, largely because of the obvious risk that it would be just diverted into the black market itself. And colleagues in Switzerland applied a typically Swiss approach to tidying up this system and realized that you needed supervised prescribing clinics where if you were going to use this approach with this entrenched group where other treatments hadn't worked, it needed to be completely supervised in the clinics. The clinics needed to be open every day of the year, Christmas Day, New Year's Day, every day of the year, so that the patient came into the clinic and there was no risk of leakage out there into the black market. We were very interested in bringing this approach back to the UK. We worked with colleagues around different European countries and North America to set up trials that each one was different, but there were 6 randomized trials around the world looking at this approach and essentially taking this group who appeared to be untreatable. We brought them into this randomized trial. A third of them received the best of oral methadone treatment, so that would be the standard treatment, where we made it as good as we could. We called it optimized oral methadone treatment. A third received a supervised injectable form of methadone, and another third received the supervised injectable heroin treatment. So essentially the same group gets sent off in 3 different treatment directions, and then we study how they do in terms of the extent to which they successfully break their contact with the black market, the extent to which they quit their street heroin use. And we also measure how their physical health and their well-being change and their involvement with any criminal activity and their family links. So what did we find? Well, when we examined them again at the 6-month point, that was where we decided we were expecting to be able to see changes if they were going to occur, what we find is huge differences. We find that the group in the supervised heroin treatment have to a much greater extent quit their involvement with street heroin use. They instead of supplementing it and increasing it, they have largely quit their heroin use. Some have totally quit it, some have disengaged from it but still occasionally lapse, whereas the other group have shown some improvement, but nothing like the extent to which that group have made those improvements. Now, our next work is then looking at how that then continues over time, the extent to which those people then, from that platform of improvement, make further improvements over the subsequent months and years. And that's the subject of looking at the data next year. But what is very clear And it's the same finding that we find from the studies from Switzerland, the Netherlands, Germany, Spain, Canada, as well as the UK, is that consistent finding that you can engage with this group and make improvements where they appeared to be impossible previously. Finally, we're then wanting to know, where does that lead us? How does that translate into a policy or a clinical practice that deals with this most needy group? And within the UK, that's now been recognised as a rarely necessary, but when it is necessary, crucially important second-line treatment for this entrenched treatment group. We have 3 clinics thus far established in the UK that provide that treatment, and within those clinics we're looking at new imaginative ways to try to make it more available to a wider geography. We're also looking at whether there might be other medications instead of the injectable heroin that might deliver the same benefit, and we're studying whether there's cost effectiveness to that. It's counterintuitive, but when you look at it, the existing treatments were failing to deliver any benefit. So this treatment, even though you're needing to open every day of the year, is actually delivering a benefit, and that more expensive treatment delivers benefit more cheaply than a failing cheaper treatment. That rollout, that transfer from the research laboratory into clinical practice and into policy is very much what we need to be doing.